The topic of the chronic cough. Cough is a common symptom, is not a disease. And acute cough is the most common, probably significant symptom that go to pediatric practice. Yeah. So it is an important and a common topic. So it is actually a defense mechanism. Anything that comes to harm in the respiratory tract, you make us reject it. We define chronic cough as more than 4 weeks persistently. The British Thoracic Society like to extend it more than that, but most societies stick with the 4 weeks duration. And it may be classified into expected. If you watch any child or even adults, there is some cough every now and then in the day. What is that? There is no disease. There may be a trivial stimulus and maybe none. So expected cough is normal, maybe several times a day. That's not a big deal. Non-specific, the dry cough, and the chest X-ray is normal. And the specific can be wet or dry and may be associated with abnormal chest examination or chest X-ray, or other symptoms, dyspnea, hemoptysis, recurrent pneumonia, swallowing problems, or failure to thrive. So the first group is trivial. Second can be something, but usually simple. And the specific will be having a lot of differential diagnosis. Dr. Anne Chang in Australia is considered internationally as the guru of coughing in children. All what she does over the years studies. And this is one graph from her paper that the normal expected is the vast majority of cough. The non-specific cough is less common, and the real serious cough, the specific cough, is the least that requires our attention and detailed evaluation. This diagram shows the cough reflex. There are cough receptors mainly in the respiratory tract, but not limited to it, at any part of the respiratory tract. And when there is a stimulus that can be a wide variety, I'll come to that later, stimulates these receptors, sends a message through the vagal nerves to the cough center in the brain stem, and the afferent nerve go to various muscles, mainly the respiratory, but can be other parts of the body as well. So there is a pathway for that reflex, the cough receptors, sensory nerves, afferent pathway, cough center in the brain system, an afferent pathway, and the effector respiratory muscles can be the abdominal wall, diaphragm, intercostal muscles, pelvic, sphincters. Some people will cough and urinate. Cough receptors are throughout the respiratory tract and adjacent organs. Larynx, trachea, bronchi, lung, pleura, diaphragm, esophagus, ear canal, liquid tympanic membrane. Notice that when we clean the ear with a Q-tip, many of us can cough. And in the lung, there is rapidly adapting receptors, myelinated fibers in the epithelium, pulmonary C fibers in the alveoli, and bronchial fibers in the airway. You see, that system is relatively complex. The cough stimuli can be mechanical or chemical, can be from inside the body or outside, and can be a variety of irritants or tussive agents. So the mechanical from body anywhere in the respiratory tract or the ear canal, mucus secretion, which is also a part of a defense mechanism, inflation or deflation of the lungs, instrumentation, even just putting the tongue blade can be thermal, cold air, particularly in children with hyperreactive airway disease or asthma. Also hot air, so extremes of temperature. Cold water ingestion through the esophagus stimulates the receptors in the esophagus. And the chemical can be hot stuff, session, acidic stuff. Nicotine as a chemical apart from the smoke itself. And osmotic agents. If we nebulize saline or hypertonic saline in particular in the bronchial tree. Inflammatory agents, histamine, that's either from an allergic reaction or intentionally doing a histamine bronchial challenge, more commonly methacholine or mannitol. Bradykinin is a strong mediator of allergy and bronchospasm, and certain prostaglandins, prostaglandin E2 and F2 alpha. All these that I hate most, man-made stimulants to the cough, is the tobacco smoke, which combines the hot air, irritant gases, irritant particulate matter, and the chemical nicotine. And this is a very common man-made thing, and many parents don't realize it. The person thinks that passive tobacco smoke exposure is not that important for the child. When we look at the effect of the smoking on the risk of asthma at a young teenager group, according to the family history and the maternal smoking. Maternal because the child spends most of the time with the mother than the father usually. And this is even during pregnancy. So the parent asthma, so the inheritance of the tendency to be asthmatic, if it is yes, and if the mother is smoked during pregnancy, even before it comes out, then it is the highest. So we need the genetic, but the mother smoke will be bad. And this is postnatally. A beautiful girl, the mother is doing a good job in reading, not putting her on the carpet to watch TV or an electronic gadget to play with, but on her lap and reading for her. Very commendable. But this is out of place. And I found that passive exposure to tobacco smoke in children reduces the child's lung function, increases the bronchial reactivity and inflammation, increase total IgE level, which is the mediator for allergy, increase the asthma and the allergy prevalence, and increase the respiratory infections. Who wanted all that? And many parents don't realize that this passive tobacco smoke can cause all this in a child. The ear cough reflex. It can be a puzzle sometimes that the child has been evaluated for cough with expensive techniques and a lot of medications, and later the doctor discovers, particularly if the child was pulling on his ear, discovers little foreign body in the ear. That reflex works in about up to 4% of people. There is auricular branch of the vagus nerve is present, and its mechanical stimulation in the canal or in the tympanic membrane will stimulate the cough. So chronic cough lasting more than 4 weeks have been reported. Secondary foreign body in the ear canal, earwax, cholesteatoma, which is a bad disease, aberrant sensory nerve regeneration after trauma. The foreign body in the ear canal has been in some patients very tiny foreign body, a tiny piece of paper. And in one patient, an adult, was a hair. entered, stuck to the tympanic membrane, and stimulating. The cough reflex all the time. The epidemiology of chronic cough is among the most common cause of repeat seeking of medical care. Acute cough, many parents, even they don't care to take it to a doctor. So, well, he has cough, he has a cold. The other children in the school or at home have it. We'll just let it take its course, give them something, homemade thing or over the counter, and the time will take care of it, but not chronic cough. Incidence or prevalence of chronic cough has been up to 7% in preschoolers, up to 15% in older children. And according to a questionnaire completed by the parents, cough without wheeze or upper respiratory infection was reported in 10% of children 7 to 9 years and in 22% of preschoolers. In the United Kingdom, 30% of primary care encounters in children up to 6 years of age were due to respiratory illness in general. Cough accounted for more than 8% of all presentations. And in the United States, cough is the fourth leading cause for emergency department visits across all ages. It's accounting for 3% of all presentations. Everybody comes to the emergency department. Most common symptom to visit the doctors in the United States, just cough. How we evaluate it? Knowing that it is a symptom, not a disease. The medical history is very important. I say the old-fashioned doctors here, just me and Dr. Herbst. I think the others are younger. We treasure to be doctors, not instrumentation. We treasure the clinical skill. I didn't count you, Ernst, you're a young man. The clinical skill, you take it anywhere you go. In the jungle, you have it. And the physicians succeeded and will continue to succeed if they maintain a clinical skill of taking a good history and physical examination. So the history, the present illness, we'll go in detail more on that, can be very helpful to reduce the cost of evaluation and to have intelligent evaluation. Past history of the child, family history, and environmental history. Physical examination, often radiologic studies from simple to complex procedures, and the other selected tests, pulmonary function, CBC, differential, sweat chloride, and many others. So we go in stages to find out the underlying cause. So in the medical history, when did it start? Where were you? What were you doing? If the child was just sitting around and was playing with Lego pieces or tiny plastic things, are going to probably it's a foreign body that was taken. If one was eating, so circumstances, the initial symptom, was it like choking? Of course, what happened? Ended up to the emergency room or coughed for some time and disappeared. Or took some water and whatever in the esophagus was swallowed and the cough is gone. And what triggers it? If the parents can know when he exercises will cough, or when he's eating or drinking, or when he goes around somebody smoking. Relationship to exercise, stress. Many children with hyperreactive airway disease, particularly if it is asthma. They will come back from school coughing a lot because either they ran a lot or the teacher scolded that child for something, homework. Environmental exposures, when you go to certain place, will cough more. Laying down, suggesting GE reflux. Sleep, postnasal drip, GE reflux, aspiration. The course of the chronic cough, the spontaneous or in response to medication or environmental change. Well, since we moved from that house, cough disappeared, or since we entered that new house, the cough has been going on. The onset during early infancy suggests congenital malformations, conditions predisposing to aspiration, or chronic pulmonary disease, bronchopulmonary dysplasia, or cystic fibrosis. Cough that begins suddenly while playing or eating, especially in the toddler, should raise suspicion of foreign body or fistula. The most common age of taking foreign body in the mouth with children toddlers are fascinated by it, is from 6 months to 2 years. We assume that after 2 years they became wise enough and educated, don't put that in your mouth. But developmentally, they started from 6 months to pick and put in the mouth. Cough that begins suddenly while playing or eating, especially in the toddler, should raise suspicion of foreign body or a fistula. Cough following exercise or exposure to cold air, allergens, or non-specific irritants, such as asthma. And if there is a chest pain, pleural disease, particularly if it is well-pointed and severe and with aching inspiration, it just very pointed. That's a pleural inflammation. Or cardiac arrhythmias. More in the medical history. Is there any associated fever with it? Breathing difficulty, night sweats, weight loss, suggesting tuberculosis. Comorbid conditions, dysphagia, heart disease, neuromuscular disease, or eczema, that's the skin. Why is it here? Because about 2/3 of infants who have infantile atopic dermatitis will have respiratory allergy later. 2/3 of them. So we take their cough, particularly if it persists, seriously. We think that it is probably asthma started in them or allergic rhinitis. If it is wet cough, we think of infection. If it is excessive, thick mucus, expectoration, bronchiectasis, or cystic fibrosis, immune deficiency, ciliary dyskinesia, we are missing it. I don't know, and there's no pulmonologist here to tell us when was the last time they picked up this. We did not pick up one for a long time, but I admit we are not thinking of it. Or congenital malformation. Hemoptysis is a bad sign. It indicates some damage to bronchiectasis, tuberculosis, there are fungal infections in particular, heart failure, hemosiderosis, neoplasm, foreign body, vascular lesions, endobronchial lesions, or clotting disorders. Cough associated with malabsorption or failure to thrive should be suspicious of cystic fibrosis and immune deficiency. Medications that are more common in adults than in children, cytotoxic drugs frequently will irritate the respiratory tract, ACE inhibitors if they are taken. So if we look at the cough characteristic, again, this is by history and by examination, by listening to the cough. Or we ask the parents imitate it. If it is honking and disappears during sleep, it is probably a habit or psychogenic cough. If it is by night only, either postnasal drip, rhinosinusitis, or asthma, is more the bronchial airway more sensitive by nights as a circadian cycle of the body or allergen in the bed. Related to exercise or environment, can be asthma, rhinitis, allergic cough. If it is with a stridor, think of laryngeal obstruction, foreign body pertussis. Paroxysmal or spasmodic with inspiratory whoop will be typical of whooping cough. Staccato cough, chlamydia, pneumonia. Barking or brassy, croup, laryngitis, tracheitis, tracheomalacia, and the habit. Productive with purulent expectoration that's worse in the morning. The child gets up, chronic bronchitis, foreign body, bronchiectasis, celiac dyskinesia, CF, immune deficiency. So by taking a good history, and if the parents help us giving us this, we tend to narrow down where are we going among all this less than the causes of cough. In the past medical history, look, what was the perinatal situation? Prematurity? Was there any natal illness? Interventions happened? For how long stayed in the nursery? What was done there? Prematurity and neonatal respiratory distress syndrome are precursors of bronchopulmonary dysplasia. Infantile eczema, again, is a high risk for asthma. Past severe respiratory infection, particularly pertussis or adenovirus bronchiolitis. Bronchiolitis is vastly a benign condition, but the worst of it is the adenovirus, was not RSV. That can cause complications, permanent complications. May predispose to bronchiectasis, bronchiolitis obliterans. That is notorious as a complication of the adenovirus bronchiolitis, or chronic lung disease. Family history, atopy and asthma, and then taking a family history in the area of allergy or asthma should be limited to parents and siblings, because atopy affects about 1/3 of the population. So any person have 3 relatives will have a history of atopy. So if we go beyond this, everybody will have a history of atopy. Focus on siblings and parents. If they are negative, we may ask about the grandparents. But the aunt and the uncle living in another state know that, well, first, the history is not clear. Who knows what the uncle or nieces have? Anyway. So we should be family history, immediate family history, to be of significance. Household smokers, chronic respiratory, and by the way, I noticed that household smokers, some smokers, some smoking material is hypoallergenic. That's when the mother is smoking it. And very allergenic if it is the mother-in-law. Chronic respiratory illness or infections in the family members, close contacts, should be infection, again from the relative. Family dynamics may contribute or even the cause, and the psychogenic or the habit cough. The child wants attention, so that's the easiest that they can do, coughing. Environmental history inside the house first, allergens, irritants, industrial pollution nearby the house, and in certain communities, parasitic or fungal infections. Physical examination. How does the child look like? Does he look sick or look happy? What's the temperature, respiratory rate, heart rate, the growth? Is there cyanosis? Is there obesity? Finger clubbing from chronic pulmonary disease or a heart disease, cyanotic heart disease. Cough characteristics, the voice, tachypnea, halitosis, indicates there is some infection, upper respiratory or lower. The ear, nose, and throat. If there are any deformities, nasal obstruction, rhinorrhea, and the tonsils and the adenoids, are they enlarged? Pharyngeal cochlear stoning, indicating chronic postnasal drip. Look at the ear canal and tympanic membrane. You might find that little thing there stuck. And your reputation in the community will be, wow, look at that smart person. Didn't cost us any money after we spend all this money and taking x-rays and found a little piece of paper there in the ear. Look at the chest from outside, how it is moving, that there is hyperinflation by appearance, and then auscultation. You define the nature of the lesion, if it is in the lung and where. Is there any neuromuscular disease? And findings that may suggest certain underlying causes. There are plenty of them. So we looked at the child. Child has failure to thrive, must have a chronic disease. It's tachypneic or dyspneic. Again, there is a problem in the lung. Cyanosis in the heart or the lung. Digital clubbing, suppurative lung disease or cyanotic heart disease. Lymphadenopathy, neoplastic disease or tuberculosis. Chest wall deformity, any pulmonary, airway, or parenchymal disease can, because the mechanics of the breathing from early age is different, there will be secondary chest wall deformity. Lung auscultation, wheezing will indicate narrowing of the airways. Complete obstruction of an airway will not cause any wheezing, which is worst. Silent chest is bad. That means complete obstruction in that area. But if there's wheezing, there is partial obstruction. If it is rhonchi from secretions, crepitations, crepitations indicate alveolar secretions. It's telling me that I should finish. Is that true? Still I have time. Good. Decreased breath sounds from consolidation or atelectasis in that area. Cardiac abnormalities, associated airway abnormalities. There are pointers again by Anne Chang about there's chest pain, productive cough, hemoptysis, current pneumonias, hypoxemia, previous lung disease, exertional dyspnea, dyspnea at rest or tachypnea, chest wall deformity, auscultations, chest X-ray abnormalities. All these direct us to where the disease. These point out to pulmonary, another list direct to cardiac. Where is systemic pointers, cardiac abnormalities, digital clubbing, failure to thrive, medications, neurodevelopmental abnormality, fever, immune deficiency, feeding difficulties, and history of contacts with chronic infections. So we took a good history and examination, and we collected valuable information. What will we do of tests? Every person with chronic cough should have a recent CBC with differential. Chest X-ray, finding may suggest certain disease. Sinus X-ray, or preferably CT, which is more informative than the X-ray of the sinuses. Spirometry, if the child is 5, 6 years old, he can do it. And it can be post-bronchodilator if there is obstruction to see if it is reversible. And if it is normal, maybe post-exercise to see exercise is a stimulus to bronchospasm in about 2/3 of the asthmatics. We may need to put PPD or better quantiferon to differentiate between old infection or vaccination with BCG versus active infection. Pertussis test and sweat chloride test. So the X-ray, we can benefit a lot from it. Their bilateral bronchopulmonary accentuation with or without hyperinflation or focal consolidation. We think of certain diseases, asthma and CF in particular. Asymmetry in aeration or vascular markings. This may be partial airway obstruction from foreign body vascular ring or bronchial stenosis. There's right middle lobe infiltrate, that's atelectasis from mucus plugging or a foreign body. Pleural effusion or pneumothorax, parenchymal lung disease. Peribronchial accentuation with macronodularity or road, the so-called railroad, sign that's bronchiectasis. Hilar adenopathy, mycobacterial or fungal infection, sarcoidosis, neoplasm. Enlarged heart or pulmonary artery, heart failure, pulmonary hypertension. Shifted cardiac shadow, may be substantial atelectasis. Right-sided heart, situs inversus, that can be associated with the ciliary dyskinesia, the whole syndrome. Multiple lung infiltrates. We'll think of a rare condition that you are missing. It's called milk-induced pulmonary disease, Heiner syndrome. I will come to that later. So when you do a CAT scan of the sinuses, it's much better than X-ray. And you see in this case, the right side sinuses, all of them are opacified compared to the well-aerated maxillary and ethmoidals on the left side. You see with various cuts, the right maxillary is completely opacified and the left maxillary is substantially obstructed. Look at the ethmoidals. One side there, almost all of them opacified, and the other side, there is also thickening and some opacifications. So the CT sinus is not the CT of the head, so that they can do the brain and very expensive, but just as CT for sinuses to be cheaper and informative. And sometimes you find unexpectedly the person has all the sinuses opacified. That's pan-sinusitis. Further selected test, chest X-ray during inspiration versus expiration or decubitus to know whether there is foreign body in one area. High resolution CT of the lung. Spirometry for older children. Allergy evaluation, may starting with the total IgE level, that's as a thermometer of atopy, and then look for the specific allergens, usually by skin testing. Sometimes, if there's a small number, we may do on blood, the serum. Immune deficiency screening, IgG, A, and M, these are the protective immunoglobulins, and specific antibodies. The person may have a total IgG, okay, but the specificity is lacking. So we get specific IgG to tetanus, diphtheria, pneumococcus. Esophageal pH monitor, or say I'm going to try for 1 to 3 months anti-GERD therapy to see. And then we may go to prove it with pH monitor. Rhinolaryngoscopy, looking for abnormalities. Bronchial challenge, methacholine or mannitol, if there is cough, we suspect the so-called cough asthma equivalent. Manifestation of the asthma is just limited to cough irritation only. But if we give them a stimulus of the methacholine or mannitol may show clearly drop in the pulmonary function. We may need bronchoscopy, may need to take the bronchoalveolar lavage to examine it microscopically and culture, and may be taking biopsies. And in the rare Heiner syndrome, we may need to look for the milk-specific IgG antibodies by precipitation test or by ELISA, more commonly. Spirometry is easy for pulmonary function, particularly if we do the flow volume loop, which is done also by almost all recent machines. So the expiratory loop is the upper, inspiratory is the lower, the vertical axis shows the flow rate, and the horizontal shows the volume. And this is the shape of the normal. If there is obstruction, extrathoracic, in the neck, that will be both loops will be blunted. If the obstruction was variable, it moves around, not sitting all the time, like the vocal cord dysfunction. It's not fixed. Like that, it will be only the inspiratory that is flattened. So it can be very informative. If it is asthma, it will be just the inspiratory will be sagging and will give a bronchodilator will be straightening it out. A word about the milk-induced pulmonary disease. That I said, we miss it, described by Douglas Heiner. It is a chronic or recurrent, lower respiratory symptoms, often associated with upper respiratory and sometimes GI symptoms and failure to thrive. And failure to thrive because it is neglected, it's not diagnosed. Chest X-ray may show various abnormalities of any kind. It may have eosinophilia and or iron deficiency anemia. The iron deficiency anemia is either secondary to bleeding in the GI tract or in the respiratory tract, causing hemosiderosis. Serum precipitating antibodies, because these are the IgG type, not the IgE, to multiple cow milk protein fractions. Milk has more than 40 individual proteins. So the precipitating test will see in the agar multiple lines, meaning when an antigen meets its antibody in the serum, in the agar, they unite together and make a line. Resolution will be in a cow milk-free diet, but this is for the person who think of it and say it is being missed. Over several years, I accumulated 8 children. Their ages were 4 months to 29 months. They were fed cow milk from birth. They have low respiratory symptoms, and the onset started between 1 month and 9 months. There were abnormal X-ray in all of them by definition. All improved in cow milk elimination. We tried to persuade the families to prove it by challenge. Only 2 agreed. The others said, no, don't do it. We are happy like that now. I'm not agreeing to please your scientific curiosity, to induce it again. We spend a lot of time to get rid of these symptoms. Those 2 definitely were positive by challenge. Milk precipitation test was all, because to have symptoms and have abnormal X-ray and have precipitating antibody, that completes the diagnosis. Iron-laden macrophages indicates bleeding in the lung for hemosiderosis were present in 2 of these 8. One patient was hemoptysis and anemia, and another patient was hemoptysis, but was not tested for the iron-laden macrophages. Eosinophilia in most of them. Total IgE was increased in 2 out of 5, but it's not an IgE-mediated disease. Milk RAST, or a specific IgE in the serum, was positive in 1 of the 4. It is not an IgE-mediated disease. So we don't discover it by skin testing or a specific serum IgE, but we can get the precipitating antibodies or by ELISA to look for IgG antibodies. And this is one patient of those 8. started in this X-ray showing, in addition to the clinical symptoms, have bilateral infiltrate and right middle lobe atelectasis. The doctor who initially saw this patient, very senior pediatrician, it happened that he knew Heiner himself, and he knew that I was trained by Heiner. So he sent the patient to me with, he said, until you go to Dr. Bahna, just avoid milk until you go. He didn't do any evaluation other than just avoid milk. And came, symptoms disappeared within a few weeks, and the chest X-ray showed marked improvement. This is one of the two patients who agreed that we challenge, give milk back. And look here, milk for 5 weeks, symptoms came back, and the recurrence of the pulmonary infiltrate. This is the precipitating antibodies for that child. The cow milk as a source of allergen in a well in the agar. The serum of the patient while on milk versus avoiding of milk, and the other wells are controls, negative. And see when there was, child was taking milk, the precipitating line was very thick and strong, became very pale when it's avoiding the milk. Of course, the B cell will continue to produce for a long time the antibodies on that. CT of another patient in that series, and the panels A and B showed consolidation, right upper lobe interstitial disease, very bad X-ray, but they became clear lungs 3 months after milk elimination. Look at the difference that happened. Bilateral infiltrate after reintroduction of the milk have started to cause problem. But this is the cleanest. And took from one of the two patients was pulmonary hemosiderosis. Took gastric washing because young children swallow their sputum. So we find the iron-laden macrophages stained by the Prussian blue stain, and a lung biopsy showed much clearer. And there's another recent one that was here 2 years ago in the ward. Terrible chest X-ray, admitted with severe anemia and still admitted in the ICU. The hemoglobin was 2, hematocrit was 6, but there was no source of bleeding in the urine or in the stools. Was quickly treated for the severe anemia and given iron. The X-ray showed significant alveolar airspace consolidation and infiltrates throughout the left lung with interstitial infiltrate. The Prussian blue stain of the bronchoalveolar lavage, look at all these blue iron-laden macrophages. The macrophages are the police, the soldiers, the janitors of the respiratory tract. Find any foreign material, whether tobacco smoke particles or any dust, or red blood cells are foreign body. You are not supposed to be in my space here. You're supposed to be in the circulation. Why are you coming here? I'm going to eat you up. But you eat it up, but they cannot digest the iron of the hemoglobin. They can eat the cytoplasm and that. So it's very good, the diagnostic problem. Last but not least is my favorite of all. The habit. We are avoiding to call it psychogenic because parents don't like that. My child is not crazy, and I'm not crazy. So let's call it a habit. This dry cough, repetitive several times a minute, barking or honking. In some cases, it's softer and appears as repetitive. Repetitive is important, and barking or honking. It is during the day, but not while asleep. All other coughs are worse by night. It's worst in the presence of adults, increases with attention, decreases by distraction in some activity. Usually ceases when the child is asked to stop coughing for a while. What I do it in 2 stages. While I'm taking the history from the family, first I have to make a relationship with the child, pay attention to him at the beginning. And after that, I say, all right, I will examine you after I talk to your mother. I told mother he's continuing coughing more and more because here are 2 adults being present. Then I say, Johnny, would you mind if you stop coughing for a minute until I finish with your mother, then cough again? And he does it. If he didn't do it, when I examine, when I auscultate, I say, can you stop just, I listen just for half a minute, that's it. Then you cough again, and he will stop it. And say, all right, you can cough now. And you'll cough again. Now after that, I will take the mother out in another room near the room of the child, and I will be with the child for a while. I ask him, what makes you cough, and so forth and so forth. And then I leave him. He was coughing while I was with him. Leave him, I go to the mother. And the doors are open, but are not across from each other right away. Talk to the mother, you have a healthy child. All the x-rays that were done fine, you give a lot of antibiotics, you are going from one doctor to the other. The child said, what's wrong with him? Say, do you hear him now coughing? Oh yeah, no, he's not. Do you know why he's not coughing? Because nobody is with him. Now when we go back, he's going to cough. What do you mean I'm crazy? No, it's a true disease called the habit cough. So to cut that out, we are not going to talk about it at all. And I'm going to give him a medicine to tell him that will stop. But it's not an antibiotic and not a cough suppressant either. And may prescribe any simple medicine with reinforcement to the child. We found the problem, and you will be great, and you are not going to cough again. And you're just going to make me a good doctor, and I will thank you for that. Okay, here it is, and I'm going to see you again. And I am confident 100% that you will be stopping the cough. But take the medicine regularly, exactly on the time, and if you want your mother to remind you, be nice to her. Make the whole ordeal. The problem is not always in the child. The mother is not happy to live without prescriptions of new medications and without x-rays and blood tests and all this. She wants more. But sometimes we succeed in them, sometimes she leaves not convinced, unfortunately. So this, you know, there are multiple doctors went, medications, x-rays, lab tests. Every doctor have to do something for the fees that they're going to take. It is rare but very disturbing. Rule out take disorder, that is kind of can be a neurological problem. Treatment behavior modification. What's the treatment of chronic cough? It's the cause. All the lecture is about the evaluation of chronic cough. If we need to complete it, we need 2-3 days for each condition. A speaker speaks for half an hour to 1 hour about each disease. Then determine what is the cause of this chronic cough. What we will do in the meantime until we find the cause, antibiotics are not going to be effective unless this truly to infection, and infection is usually acute. But to be persistent for several weeks, that's unlikely. Can we stop the cough? Why do you want to stop it? Well, we will suppress it. Maybe I'm blinding myself if I give a strong medication, antitussive medications. We have to look for the cause, and we investigate fast. Well, how about the codeine. Isn't it codeine good sedative for the cough? Well, this is a review of 70 studies that fulfilled a good criteria. It revealed the absence of any randomized controlled trials to support or oppose the use of codeine. Means it was not studied really in the treatment of childhood cough, either chronic or acute. The lack of sufficient evidence to support the use of these medications has been consistently reaffirmed by medical experts in international chronic cough guidelines and by medical and pharmaceutical authorities in the USA, Europe, all over the world. Given the potential of adverse events, adverse side effects of respiratory suppression, if there is secretion coming, I want it to come out. If there is foreign body, I want it to move, to be unlocked. I don't want to stop my cough center there. So shut up. No, act. Do something. And the potential of opioid toxicity, particularly in children, authorities recommended that contraindication of codeine under 12 years of age. The issue is the etiology, and the management should be directed towards it. So in conclusion, chronic cough is disturbance to family and the finances, a very wide underlying causes, respiratory or extra-respiratory, and it can be caused by a variety of disorders that require a thorough investigation, starting by a detailed history taking and appropriately selected tests. Go step at a time. Identifying the underlying cause and treatment may require a multidisciplinary approach. The pediatrician at the center involves specialists in the pulmonary, in allergy, immunology, otolaryngology, radiology, gastroenterology, infectious disease. Not all of them at the same time, but where is the most likely, one after the other. So this is the last slide, the chronic cough. If there are signs of severe illness and the cough characteristic of a specific illness, cough not responsive to the usual treatments, that the cough medications and antibiotics, seek consultation, either more in the pulmonary or more in the allergy and immune deficiency side. If there are no signs of severe illness and the cough not characteristic of a specific illness and the child is thriving well, watchful, you are not going to neglect, just let us, particularly if it is just still has been a few weeks. If cough persists, because our body is automatically renewing and rejuvenating, and God taking care of us, particularly of the children, because they are more innocent than adults. If the cough persists, if it is a wet cough, that probably there is infection, and we have to give a prolonged course of antibiotic, preferably guided by culture, and not just a few days. If no resolution, then we need the consultation. If it is dry cough, probably it's not an infection. It may be a hypersensitivity, an inflammatory reaction by allergy. So we may give the inhaled corticosteroids for a short time. If no resolution, then let's see, is it more likely a pulmonary problem or allergy or immune deficiency problem? And thank you. If you need to read more, most of this present in an article that was published in a journal that probably most of you get it, the Pediatric Annals. Thanks. Good. Any comments, additions from your experience? Probably you see the cough more as a pediatrician than us. We get it towards the end of the line after everything fails. Say it may be allergic or immune deficiency, but I hope you can think earlier of the role of the pulmonologist and the allergist in chronic cough. Dr. Koo, what's the cough happens in the nursery? I hear from the nursery cough coming to the 5th floor. of the attendant, you mean?
Yes.
The attendant. No, truly, you discover abnormalities in these babies.
Well, for the nurseries, it's always congenital malformation first, because foreign bodies usually don't happen too much. As far as spit up goes, every baby spit up, that's normal. The issue here, do they have any subsequent problems?
Yeah, abnormal. What abnormalities do you discover usually? Fistula? Or
Cough doesn't happen too often in babies, but when it does, you talk about vascular ring, tracheolation, and all that kind of thing, and many of which there's nothing much you can do other than time.
the diagnosis.
Beg your pardon?
It is diagnosis.
Yes,
Discover.
the diagnosis is a key thing. Hopefully we don't miss too many bad things.
Will tracheomalacia start to be symptomatic early in the nursery or later on?
It can be in the nursery.
Good. Right. Thank you. We go to stump disease and prevent death.